So we're going to pick up the gastric cancer lecture with part 2 here. Basically talk about the management of gastric cancer, talk about general management, and then we'll talk more specifically about peri-op chemo and chemoradiation, and then finish up talking about D2 versus D1 lymph node dissection. So I'm just going to briefly talk about management by stage, or excuse me, by T stage. So TIS or T1A, so that's going to be in the lamina propria and the muscularis mucosa, low chance of lymphatic disease, so these can be resected endoscopically. So again, endoscopic resection or surgery. There are some exceptions here where things cannot be resected endoscopically if you have lymphovascular invasion or a large tumor more than 3 centimeters. But just know the basics. If it's T1A or below, you can resect it endoscopically. T1B, now you're in the submucosa. Again, this is sort of a line of distinction that you have to remember. Now you're worried about lymphatic spread, so these patients get surgical resection. T1B is the only group of patients, T1B N0, only group of patients that can have surgical resection without any adjuvant or neoadjuvant therapy. That's a very, very small subset of gastric cancer. It's rarely seen. So clinical T2 or clinical N positive, they need multimodal therapy. So they're either going to get perioperative or preoperative chemo or chemoradiotherapy, and we'll go into that a little bit. But just know multimodal therapy for clinical T2 or above or any N positive patients. Metastatic disease, unfortunately common, often peritoneal spread of this disease, and these patients get palliative therapy. I'm not going to go into that too much. So once again, take home point here. Once the tumor is into the submucosa, they need a lymph node dissection. So T1B gets a formal resection with a lymph node dissection. T2 or into the muscularis or beyond, these patients need multimodal therapy. So what are we talking about when we talk about multimodal therapy? There are 2 big chemotherapy trials that I want to go over that you guys need to be aware of, and then we'll talk a little bit about chemoradiation, and then we'll get into surgery a bit more. So the first big chemotherapy trial, the MAGIC trial, this was published in 2006 in the New England Journal of Medicine, perioperative chemotherapy versus surgery alone for resectable gastroesophageal cancer. So 503 patients these were resectable stage 2. Again, they're either going to be N positive or they're T2 plus. So again, that T2 N0, that's the line of distinction where multimodal is indicated. So these are stage 2 or stage 3 resectable. They're gastric or gastroesophageal junction or distal esophageal cancer. So all of these were included. These patients were randomized to 3 cycles of ECF, which is epirubicin cisplatin 5-fluorouracil, so ECF, 3 cycles pre-op, 3 cycles post-op, or surgery alone. So just to give you an idea, 74% of the patients were gastric cancer, 15 were lower esophageal, and then 11% at the GE junction. So this is considered a gastric cancer trial, much more than it is an esophageal cancer trial. So just to kind of look down here, so you have some idea, the groups were well matched. Most of the patients got a D2 lymph node dissection, which we'll talk about, and that can kind of play into how you interpret some of these trials, whether it was a D1 or a D2 dissection. But the bottom line from this is so in this trial, I just want to give you guys a sense of how many of these patients actually get chemo. It's a very important point to think about when you're thinking about neoadjuvant versus adjuvant therapy for gastric cancer. So in this trial, 95% of the patients started chemo. 91% of those patients that started chemo completed their pre-op chemo. A few stopped for toxic effects and a couple progressed, but overall, over 90% of the patients who started chemo completed pre-op chemo. 84% made it to surgery. Okay, so this is one of the arguments against neoadjuvant therapy is that, well, a lot of patients don't make it to surgery when they're on the neoadjuvant track, and that's not really true in these trials. So 84% made it to surgery in the chemo arm, whereas only 92% in the surgery arm, so not a huge difference. But after surgery, only 2/3 of those who had surgery, only 137 out of the initial 237, only 2/3 of those who had surgery started post-op chemo, and only 50% of those who had surgery completed post-op chemo. And that's going to be a somewhat consistent number. So 2/3 of patients who got it, who made it through surgery, only 2/3 of them started post-op chemo, and only half of them completed post-op chemo. So we just have to keep in mind that if we're relying on just post-operative chemo to provide these patients with multimodal therapy, only 2/3 of them are even going to get to start their post-op chemo, and only half of them are going to finish their post-op chemo. That's because gastrectomy is very morbid, and these patients are very run down after surgery, and they're just not able to tolerate a lot of chemotherapy. So the results of this are, sorry, so just to kind of bring that point home, over 90% of those who started chemo made it to surgery, but only 2/3 of those who had surgery even started post-op chemo, and only 50% of those who had surgery completed their post-op chemo. Just keep those kind of vague numbers, rough numbers in your mind. So these are the results of the MAGIC trial. So you can see that peri-op chemo clearly superior to surgery alone. This is in terms of progression-free survival and overall survival. P-values are significant in both of these, and there's a clear separation of the curves. So the results of this trial, perioperative ECF, 3 cycles pre-op, 3 cycles post-op, is better than surgery alone. 5-year overall survival was 36 versus 23%, so not great for either group, but a significant improvement with peri-op chemo. So as a result of this, all patients with T2 or greater or any N-positive disease require perioperative chemo or pre-op chemo. They require multimodal therapy. So the second big chemotherapy trial that you guys need to be aware of came out very recently. It was just published in Lancet this year, and it basically changed the recommendation for perioperative chemotherapy for gastric cancer. So this is a trial, the FLOT4 trial. It looked at 716 patients with T1N positive or clinical T2 or above tumors, so the same subset we've been talking about. Resectable gastroesophageal junction or gastric tumors. They looked at the MAGIC regimen of ECF, 3 pre-op and 3 post-op cycles versus FLOT. FLOT is 5-FU, leucovorin, oxaliplatin, docetaxel. So it's basically FOLFOX plus a Taxol, FLOT. They got 4 cycles pre-op and 4 cycles post-op. That's a typo. It should be 4 cycles post-op. So just to give you an idea of the patients that we're looking at here, just under half were gastric cancer, and then about a third in each arm were Siewert type 2 or 3, so low GE junction. But they were well matched between the two groups. They did a very nice job of stratifying patients here. And then just to look at these other things, most of these patients were T2 or T3, and most of them were N positive. So just to give you an idea of what patient population you're thinking of here. And then the majority of patients were not diffuse type. This is their consort diagram. Don't worry too much about it. It's kind of complicated. But the bottom line is that of patients who started pre-op chemotherapy, 97% in the FLOT4 arm underwent surgery and 98% in the ECF arm. So the vast majority of patients who started pre-op chemo made it to surgery. Again, you'll hear this argument that pre-op chemo, a lot of patients don't make it to surgery. In gastric cancer, the studies don't really show that. So, and that, again, kind of is the same as what we saw in the MAGIC trial. So one takeaway here is how many patients actually got the chemotherapy they were assigned to get. So of the patients who had curative resection in the ECF arm, only 52% started post-op chemo, only 60% in the FLOT arm. And then patients who finished all chemo, it's only 37% in the ECF arm, only 42% in the FLOT arm. So less than 2/3 started post-op chemo and less than half finished post-op chemo. Again, gastrectomy patients, very run down. It's a highly morbid operation. They do not tolerate post-op chemo very well. The other big takeaway from this trial is that there was a lot of toxicity. So grade 3, 4 toxicity, it was 24% in each arm, so about a quarter of patients are going to have a grade 3 or 4 toxicity. That's a significant adverse event. And then hospitalization secondary to toxicity was about a quarter of patients in both arms. So these are both very toxic regimens. So again, takeaway points here, less than 2/3 started their post-op chemo and less than half completed all chemo. So uh, when we talk about giving chemo to gastric cancer patients, it's generally better to give more up front because they can tolerate it much better when they have a stomach than post-op when they don't have a stomach. They lose a lot of weight and they just don't tolerate chemo very well. So looking at some outcomes here, the first one we look at is pathologic response. So the pre-op staging or the clinical staging, the TNN stages were similar between the two groups. However, the YP or the post-neoadjuvant pathologic staging, there were more T1s in the flat arm, there were more N0s in the flat arm, and there was a higher chance of R0 resection in the flat arm. So these patients that got flat were responding more than the ones who got ECIF and had lower YP staging because of that response. Additionally, in just the phase 2 portion of the trial, they looked at pathologic complete response, and they found 16% pathologic complete response with FLOT and only 6% with ECF, so a higher rate of path complete response with FLOT than ECF. So all these pathologic outcomes showed that FLOT had more response than ECF. And then looking at their primary outcome, which was median overall survival, there was a significant increase in median overall survival with FLOT of 50 months versus 35 months. So over a year added to these patients' lives with FLOT over ECF. You can see nice separation of the curves, the p-value 0.012. So this is clearly a positive trial showing FLOT to be better than ECF. So take-home point, NCCN guidelines no longer include ECF. They recommend FLOT for patients with good performance status. However, they do acknowledge the high toxicity rate of FLOT, and they recommend FOLFOX for those who cannot tolerate FLOT. So again, FLOT is basically FOLFOX with a taxane. There's some data from the metastatic setting that the taxane doesn't actually add all that much, and maybe FOLFOX is just as good. So patients with really good performance status who can handle the triplet, give them FLOT. Patients who you don't think can tolerate FLOT should be getting FOLFOX. But you should not be getting ECF for gastric cancer anymore. So one more trial of neoadjuvant therapy that you guys should be aware of. This is the CROSS trial. So this was neoadjuvant chemoradiotherapy plus surgery versus surgery alone for GE junction and esophageal cancers. So this is not actually for gastric cancer, but people tend to sort of apply the rationale here to gastric cancer somewhat. And this is just a big phase 3 trial that you should be aware of anyway. As far as direct trials of radiotherapy for gastric cancer, there is a phase 3 trial looking at adjuvant or post-op radiotherapy, which did show some improvement, but it's an old trial and has some flaws, so we're not going to go over that one. But this cross trial, so this is resectable esophageal or GE junction tumors. Again, the N1 or T23N0 patients, so essentially the same population we've been talking about. Patients were randomized to 5 cycles of carboplatin and paclitaxel plus 41.4 gray, followed by surgery or just surgery alone. So this is basically neoadjuvant chemoradiation versus surgery alone. Initial results were reported in 2012 and showed improved 5-year survival. This follow-up trial published in 2015 had longer follow-up results. So just looking at where these tumors were, the first thing to note is that a quarter of these patients had squamous cell carcinoma. So that's squamous cell of the esophagus, which is very different than adenocarcinoma of the stomach. So we really can't, apply the results of those patients, and we'll talk about how they did differently, or how they did as opposed to the adenocarcinoma patients at the end. But 3/4 were adenocarcinoma. Now looking at the location, most were either middle or distal esophagus, and then there were some GE junction tumors. So this is their consort diagram. So again, we want to look at how many of these patients made it through their pre-op therapy and made it to surgery. So of 180 assigned to chemoradiotherapy, 161 underwent resection. Of 188 assigned to surgery alone, only 162 underwent resection. So basically, neoadjuvant versus no neoadjuvant, roughly the same amount made it to actual resection. So 92% of patients assigned to neoadjuvant completed all therapy and went to surgery. 90% of the neoadjuvant arm versus 86% of the surgery first arm underwent resection. So again, neoadjuvant did not prevent these patients from making it to surgery. And then this is their final result. So you can see clearly the neoadjuvant chemoradiotherapy arm did significantly better, p-value 0.003. So this second KM that they include, this covers the differences between squamous cell and adenocarcinoma in their results. So the dashed lines are squamous cell carcinoma, the solid lines are adenocarcinoma. So again, when we're thinking about gastric cancer, we can really only look at these adenocarcinomas, and even that is a little bit different, obviously, because these are distal esophagus and GE junction, not true gastric. But the adenocarcinoma group did show a significant difference. The p-value is 0.038, so not quite as good. Clearly, the squamous cell group had a great benefit from neoadjuvant chemoradiotherapy, which makes sense. Squamous cell is known to be very sensitive to radiotherapy, so certainly any squamous cell of the esophagus should be getting neoadjuvant chemoradiotherapy. The question is, adenocarcinomas of the distal esophagus and adenocarcinoma of the stomach, should we be using neoadjuvant chemoradiotherapy? You do see that there's a significant difference there. So bottom line of the cross trial, benefit to neoadjuvant chemorads for all esophageal, but especially for squamous cell. Is there a benefit of pre-op radiotherapy for gastric cancer? So I trained at MD Anderson, so we used a lot of neoadjuvant radiotherapy for gastric cancer, so I'm just going to kind of make the case for that management. So we know that there's a clear benefit in esophageal, even for adenocarcinoma. There are multiple phase 2 trials and retrospective trials that show past CR rates of up to 30% for chemoradiotherapy in phase 2 trials, whereas pre-op chemotherapy, the best data we have is that FLOT4 trial where there was a 16% pass CR rate. So roughly, I should say up to double, and this is smaller trials, so you have to be pretty careful with this, but it does seem like there's a higher pass CR rate with chemoradiotherapy than with chemotherapy alone. Looking at NCCN data, or I'm sorry, NCDB data, pass CR is 16% with chemoradiotherapy and only 6% for chemo alone. Again, this is NCDB, so you don't know what chemo they're getting, but there is a difference between chemoradiotherapy and chemotherapy. However, even in that NCDB data, there's no improved overall survival with the addition of radiotherapy neoadjuvantly. So you may be affecting the local tumor and making your path report look better, having more node negative and lower path T stage, but you may not be affecting the overall survival because overall survival is really determined by metastatic disease. And it's possible that the radiotherapy has a local effect but doesn't affect metastatic disease. And then I just wanted to put a plug in for the case for what we call total neoadjuvant approach, meaning putting all the chemo or chemoradiotherapy, whatever you want to do, putting it all up front and not relying on any chemo on the back end. Again, we saw in multiple trials that about 90% of patients will make it to surgery when they get neoadjuvant therapy, but only about 50% will be fit enough to complete their adjuvant or post-op therapy. So if you're going to give this chemotherapy or chemoradiotherapy, give it all up front. Give it before you take their stomach out because they're going to lose a bunch of weight. They're going to be super run down by their surgery for months afterwards, and they're not going to tolerate adjuvant therapy. So that's kind of the approach that I was taught in fellowship. And just to kind of give you a sense of the MD Anderson protocol. So we do all the staging up front. They get presented at a multidisciplinary conference, of course. And then they get chemo for at least 2 months. This is usually FOLFOX at MD Anderson, so 2 months or 4 cycles of FOLFOX. And then chemoradiotherapy comes next, so that's usually 25 treatments, roughly 50 gray of radiation therapy along with oral capecitabine. So they're getting a full 3.5 months of chemo and then chemoradiotherapy, and then they get almost 2 months off. This allows them, one, to kind of recover from the pre-op therapy, but also there's data that, especially in rectal cancer, that the longer you wait to operate, the more effect that radiotherapy will have. So waiting a full 2 months to allow that radiation to really take effect, and then patients undergo resection afterwards, and they generally get no post-op therapy. They just get monitored for recurrence, and then if they have a recurrence, they get treated at that time. So finally, getting to surgery. So the surgical options for patients with gastric cancer, basically a total gastrectomy versus a subtotal gastrectomy. So in America, any patient with a proximal gastric cancer and generally with a diffuse type is going to get a total gastrectomy. Subtotal gastrectomies are reserved for patients with distal intestinal type, where we feel we can get a good margin but still leave a pouch of proximal stomach, which will help the patients have some reservoir to be able to eat a little bit more. Proximal gastrectomies are described in some places, but are associated with severe reflux and a poor lymph node dissection, rarely done in Western countries. Finally, distal gastrectomy is preferred for a distal gastric cancer where a greater than 4 centimeter gross margin is feasible. So technically, you only need a negative microscopic margin, but typically the recommendation is to get a more than 4 centimeter gross margin to make sure you get that negative microscopic margin. And then the trick of a distal gastrectomy is you need to do an adequate lymph node dissection while maintaining good blood supply to the remnant stomach. So the final thing that we need to talk about to cover gastric cancer and the final area of some controversy is lymph node dissection. So the things that you need to know, a D1 dissection is stations 1 through 6. So these Japanese classification of lymph nodes around the stomach, it's all very confusing, and I don't want you guys to get too caught up on trying to memorize these, but a D1 dissection is 1 through 6. It goes 1, 2, so 1 and 2 are around the cardia, left and right, and then 3 is lesser curve, 4 is greater curve, and then 5 is supra, and 6 is infrapyloric. So basically, 1 through 6 is the 6 stations that are immediately around the stomach, and so that's a D1 dissection, taking the lymph nodes just around the stomach, nothing that's posterior or deep to the stomach. Okay, and then a D2 dissection. So a D2 dissection is the nodes around the left gastric artery and then the nodes around the immediately adjacent arteries. So just to try to break it down, station 7 is the left gastric artery, so we need to take those when we're taking the stomach. That seems to be probably the most important. So if you're going to do a D1 plus, do the D1 and then make sure you take station 7, those nodes around the left gastric. Now to do a true D2 dissection, you need to take 9, which is around the celiac, the root of the celiac, 8, which is around the common hepatic, and then 10, which is at the splenic hilum, and then 11, which is along the splenic artery. So 7, 8, 9, and 10 are left gastric, common hepatic, celiac, splenic hilum, and then along the splenic artery. And we'll talk a little bit about the data around these. So D1 versus D2 dissection, which one should we be doing? So D2 dissection is the standard in Eastern countries. There's data from Korea and Japan that shows that there's better long-term outcomes with a D2 dissection. So that's what they do. In Western countries, there were 2 big European trials that failed to show a benefit of the D2 dissection. The British trial, which is called the MRC trial, there was no difference in 5-year overall survival between D1 and D2. And then there's a Dutch trial that we're going to go into that showed no difference. So D2 dissection was essentially not the standard in Western countries, and most people will do kind of this D1 plus, which we'll talk about. The consensus, and this is the NCCN recommendation, is that you need at least 15 nodes, but D2 is not necessary. However, they do say that if you can do a D2 dissection with minimal morbidity at a high volume center, it's recommended. So let's talk about this Dutch trial, the Dutch D1 versus D2 trial. So this was initially published in 1995, and then there's some long-term follow-up. So randomized comparison of morbidity after D1, D2. So this initial paper just looked at morbidity. 996 patients with resectable non-metastatic gastric adenocarcinoma. 771 of these 996 had what the surgeon called deemed to be a curative resection, and they were then randomized to D1 versus D2. So initially, just looking at the patients here, most were distals, and only a third in each arm, roughly, were total gastrectomies. This is the very interesting thing about this trial. In order to do a D2 resection, 38% of the patients ended up getting a splenectomy, and 30% ended up getting a distal pancreatectomy. So a large proportion of those patients getting a D2 dissection were also getting a splenectomy and pancreatectomy, and so there was much higher morbidity as a result. So this is again from their initial paper. Postoperative deaths, 10 versus 4%. So significant increase in death. Complications, 43 versus 25%. A significant increase in morbidity and mortality from doing a D2 dissection. As a result of that significant morbidity and mortality, they recommended no D2 dissections. So this is again what happened in the Western world. Everybody stopped doing D2 dissections. Um, so here, just summarizing initial results from the Dutch D1, D2, 38 versus 11% splenectomy, 30 versus 3% distal pancreatectomy, mortality 10 versus 4%, complications 43 versus 25%. So D2 is associated with higher rate of splenectomy, pancreatectomy, significantly increased morbidity, periop mortality. Most people in the Western world stopped doing D2 resections as a result of this. Now we get into the long-term follow-up results of this trial. This was published in 2010, and what we see in this KM is that the blue line is D2. So initially, the D2 patients do worse. And then around 3 years, the two lines cross. And then by the end, you see that the blue line is starting to do a bit better. So it seems that as far as long-term oncologic outcomes, the D2 dissection is probably a little bit better. So what they did is they broke these KMs down into death due to gastric cancer and death due to other causes, which included periop mortality. And what you see is if you remove the periop mortality and just look at gastric cancer deaths, the patients who got a D2 dissection did significantly better with a p-value 0.01. So D2 dissection does have an oncologic benefit, but the periop mortality is so high that the curves never crossed if you look at deaths besides gastric cancer. So this big difference within the first few months here is all due to perioperative mortality. So the kind of take-home point here is D2 dissection does improve disease-specific survival. And so if you can do a D2 without significant morbidity and mortality, it is indicated. So can we do a almost D2 while leaving the spleen intact and not having to do a distal pancreatectomy? And this is kind of where most American surgeons have landed. So the almost D2 includes, oh, sorry, it's a little bit out of order, but includes nodal stations 7, 8, and 9, so the left gastric, the common hepatic, and the celiac artery nodes, and then the proximal splenic artery nodes. However, it leaves alone the distal splenic artery and leaves the splenic hilum alone. So we're going to avoid doing those two, but we are going to take 7, 8, 9, and 11 proximal. So we're going to try to get the nodes that matter while not increasing the morbidity and mortality. Don't take the spleen out, don't take any pancreas, and maybe we can accomplish the same oncologic benefit without all the morbidity and mortality. So this is a picture from a publication from MD Anderson and shows what nodes they like to try to go after. So this is with the stomach lifted up, and we're looking back behind the stomach. The left gastric artery has already been cut, so the left gastric artery nodes go with the specimen, and then we're going to go after the common hepatic nodes, the celiac nodes, and the proximal splenic artery nodes. So this is the kind of almost D2 that most American surgeons are doing. So that's all I have for the gastric cancer lecture. For the BAMC residents, we'll go over some cases on Wednesday and discuss this stuff a little bit more. So thanks for paying attention. I appreciate your time.